this set of results that I'm going to present, it's going to be focused on the NRTI backbone, and what I'm going to share is that TAF-FTC is superior to standard of care second line NRTI backbone ART for children living with HIV in Africa. And this will be a set of week 96 efficacy and safety results of the CHAPAS 4 trial. So, as a background to this, it is estimated that 1.5 million children less than 15 years are living with HIV globally. 57% of these are on ART, and the majority live in Africa. Now, WHO recommends a regimen composed of 2 NRTIs as a backbone for both first line and second line ART. Now, it's important to note that the WHO guidelines are what are used mostly in Africa. So the NRTI options that are recommended here are zidovudine-lamivudine and abacavir-lamivudine, which are used sequentially between first and second line ART. So tenofovir disoproxil fumarate, or TDF, which is recommended in adults and children over 30 kilograms, is virtually the only option for the adults, but or what is used mainly in adults and adolescents. But there is an option of tenofovir alafenamide, which is another alternative of tenofovir, or another version of tenofovir, and this has been shown to have similar viral suppression to TDF, but with better renal, bone, and lipid safety profiles in several adult studies. There is limited data on TAF in children, but within the CHAPAS 4, we've observed favorable PK parameters, as I will share in detail shortly. Now, the CHAPAS 4, against this background, evaluated long-term outcomes for children switching from first-line ART, which was NRTI-based, to second-line ART. And within this, we looked at 2 randomization, the NRTI backbone, as well as the anchor drugs. I will share the NRTI backbone, as mentioned earlier, and then Mutsa will present after me, will talk about the anchor drugs. So this was the design. So CHAPAS 4 was a randomized factorial 4x2 open label trial. The children who are aged 3 to 15 years were randomized either to receive TAF-FTC or abacavir-lamivudine or zidovudine-lamivudine. There was a further randomization for the children to either receive DTG or Darunavir or Atazanavir, and then lopinavir. So all the doses were given according to WHO weight bands, and there were sub-studies that focused on pharmacokinetics as well as toxicity. So the primary endpoint was viral load less than 400 copies per ml at week 96. And then the hypothesis that guided this one was that TAF-FTC would be non-inferior to abacavir or zidovudine standard of care with a 10% non-inferiority margin. The others were related to the anchor drugs, that's atazanavir, ritonavir would be non-inferior to lopinavir, ritonavir. Darunavir, ritonavir would be superior to lopinavir, ritonavir, and atazanavir, ritonavir arms combined, while DTG would be superior to lopinavir, ritonavir, and atazanavir, ritonavir arms combined. The primary analysis was intention to treat. There was a second analysis which was per protocol, and this was for non-inferiority comparisons only. For the primary endpoint of a viral load less than 400 copies per ml, death was taken as a viral load over 400 copies per ml. And for the multiple comparisons, that is the ones with DTG being superior to lopinavir, ritonavir, and DTG superior to lopinavir, ritonavir, and atazanavir, ritonavir, there was a superiority threshold of a p-value of less than 0.03. So the 919 children were recruited from 3 countries in Africa. 397 were from Uganda, 195 from Zambia, and 327 from Zimbabwe. The children were 54% male. They had a median age of about 10 years. Majority were WHO stage 1 and 2. They had a CD4 of about 669. The median viral load was a median of about 18,000. The first line NRTI was about half Bamford and half Zimbabwe. The backbone of NRTI, the anchor drug for first line was slightly more efficacious than developing. They had been on ART for about 5.5 years. So we, in follow-up, the children were followed up very well over 96 weeks. 99% of the visits were completed, and at randomization, all the children were able to start the NRTI backbone. Only 11%, which was about 1%, only 11 children, which was about 1%, were lost to follow-up, and 98% remain on the allocated regimen. Only 5 of them, which was about 0.5%, started the ART. So I mentioned earlier that we did a pharmacokinetic sub-study within the study on TAF FTC, and we did PK parameters for TAF and tenofovir, and this was, we did this in comparison to reference exposures in adults. So what we see here in this curve is that these concentrations that are generated here were similar, or were similar to those that had been observed in adults to be well tolerated and effective. So this study is published and is accessible. Then if we go to the primary endpoint, viral load of less than 400 copies per mil, the viral suppression was high in all arms, but there was greater suppression observed with TAF when compared to Bamford or Zimbabwe, and that difference was statistically significant. Even when you looked at proportions of less than 400 copies per mil, there was greater suppression. This proportion was 89%, and then in the Bamford 3TC it was 83%, and this difference of 6.3% was also statistically significant. And when you looked at the other viral load endpoints, like viral load less than 60 copies per mil, viral load less than 1,000, differences were maintained and they were still statistically significant. And even when sub-analyses were made, like a protocol population or subgroups adjusting for either first line or baseline viral load or gender or weight, these differences were maintained. The CD4s were high in both arms, and there was no difference observed between the NRTI randomizations. The adverse events were low across all arms, with no difference between Bamford or Zimbabwe observed. Both arms. So we also looked at bone mineral density with DEXA scans. We started off with a baseline and in about 159 children. And here what we saw is that those who had low bone mineral density were 28% if we considered total body less head, 21% if we considered the lumbar spine, and 15 or 9% if we considered those who had both. So what we saw that low bone mineral density was associated with the female sex, older age, first line Zimbabwe exposure, and low BMI. This analysis is also published. Now, when we followed up the children over time, we saw no difference in changes in bone mineral density when we considered the lumbar spine. But when we considered the total body less head, there was greater increase in bone mineral density in TAF when compared to Makerere or Zimbabwe. Then the weight changes, considering weight for age and BMI for age, there was a greater gain of mean weight for age or BMI for age Z scores observed with TAF when compared to Makerere or Zimbabwe arms. Now, if you looked at this further, considering the various combinations, we try to look out for whether the combination of TAF DTG would be associated with a greater weight gain. This was not observed, probably suggesting that this greater weight gain that was observed with TAF 50C was probably as a result of growth, and because no excess weight gain was observed in the TAF DTG, which had been observed in some adult studies. So in conclusion, we observed that TAF FTC was biologically superior to Makerere 3TC, was developed in 3TC standard of care backbone. The TAF FTC was also associated with better growth with no evidence of excess weight gain. There were favorable bone safety profiles associated with TAF FTC, and these results support ongoing development of child-friendly TAF FTC fixed dose combinations. I'd like to acknowledge the participants and staff from all the centers that participated in CHAPAS 4 and all the various coordinating centers and partners, including those that funded the study and those that provided the medication, and bring you greetings from the CHAPAS 4 trial team. Thank you very much.
Great, thank you. So it gives me great pleasure to present the other half of the results on the second line anchor drugs for children living with HIV in Africa. And like Victor presented, these are the week 96 efficacy and safety results from the CHAPAS 4 randomized trial. And I'm doing this presentation on behalf of the team. So Victor has already given the overall background to the entire study. So what I will do is just concentrate on the anchor drugs. So just to say that the CHAPAS 4 trial was conducted on the backdrop of the Odyssey study, which had previously shown that dolutegravir was superior to standard of care, but CHAPAS 4 was differently designed to provide comparison of 4 different anchor drugs. So we all know that boosted lopinavir, which is the only currently co-formulated boosted PI for children, has got challenges with the formulation as well as the BD administration. And while boosted Darunavir has a high genetic barrier to resistance, even after failing boosted PIs, we know that its cost is prohibitive, and it's also not available as an FDC. Boosted atazanavir is not co-formulated for children, but we know that the once daily administration is an advantage to children. Dolutegravir, on the other hand, has a high genetic barrier to resistance. It's got low toxicity and once daily dosing. I'm going to skip the hypothesis because Victor has already spoken to these. So if we look at the treatment details, so basically what we did was we randomized in 1:1:1:1 to the anchor drugs of boosted lopinavir, boosted atazanavir, boosted darunavir, and the integrase inhibitor dolutegravir. So you will notice that children were on the randomized arm from week 0 to week 48, but after week 48, from about week 96, you will start noticing that some children were moving from the previously randomized arm. So this was a combination of a change in policy in terms of country guidelines or national guidelines, moving from dolutegravir as first line and second line in children. And a few children also changed regimens because of failure. And for some, it was they needed to go to once daily dosing in order to improve adherence. So moving on to the results, this slide is basically showing that there was good viral suppression in all the arms for a viral endpoint of more than 400 copies per mil, but we noticed that dolutegravir was significantly better than the other 3 anchor drugs in terms of viral suppression at 400. We also looked at comparing the viral suppression at less than 400, and when we now compare atazanavir, we found that it was non-inferior to lopinavir-ritonavir, which was one of the hypotheses that was being tested. Dolutegravir, we have seen, is superior to lopinavir and atazanavir. And we found that Darunavir also showed a trend to superiority, but it did not reach significance because the preset significance level was 0.03. Moving on to the other viral endpoints, we noticed that the anchor drug effects were similar at viral load below 60 copies per mil, as well as below 1,000 copies per mil at 1,000. And the subgroup analysis was also similar, with no evidence of interaction by viral load, sex, weight, or first-line NRTI backbone, or CD4 count. Moving on to the change in CD4 count, what we see on this slide is that the CD4 count increased in all arms, and there was no evidence of difference for the anchor drug randomizations. Of note is that the CD4 increased quite steeply in the first 24 weeks after switching to second-line ART. Moving on to the adverse events. So overall, CHAPAS 4 showed very low rates of adverse events, and there was no evidence of difference by NRTI randomization. So what we see, which is what is expected, is that most of the grade 3 and 4 adverse events were hyperbilirubinemia, which occurred more for atazanavir compared to lopinavir-ritonavir. Of note is that this hyperbilirubinemia was clinically not significant, and it was expected. When we compare the adverse events, dolutegravir and lopinavir, dolutegravir had fewer grade 3 and 4 events, and there was no evidence of difference for AT-modifying events or SAEs. Moving on to toxicities, if we start with lipids, so the lipid profile as a toxicity event is really important in children who we know are starting AT quite early in life and are going to be on AT for much longer periods than adults. What we see here is that there was a higher increase in both total cholesterol as well as LDL cholesterol in children who were receiving lopinavir, and that is the lopinavir here. And this was significantly different compared to Darunavir, compared to atazanavir, as well as compared to dolutegravir. So the same applied to our LDL cholesterol. We see that the mean change in LDL cholesterol was significantly higher in children who were on lopinavir best AT. Looking at change in weight and BMI for age Z scores, Victor has already shown us that these children were underweight at the start of switching to second line. So what we see is that there were significant increases in weight for age Z scores across all the arms. And when you look at lopinavir-ritonavir here, it's almost like there is actually no change in weight for age Z score. And then when we look at BMI for age Z score, the mean change in BMI for age Z score is quite similar to the weight for age Z score. And we find that, again, the other 3 drugs did much better, and there was not much change in the BMI Z score for the children who were randomized to lopinavir-ritonavir. And looking at the change in weight now for the different ART combinations, this was important to show because we worry about dolutegravir and weight gain, particularly when it is combined with TAF, because this has been shown to happen in adults where that combination is causing more weight gain. So what we did is we compared weight gain across the different ART combinations, particularly DTG and TAF. And what we see here is that there was no excess weight gain among, particularly when we look at children who were on DTG. This is showing the standard of care arm as well as the TAF, and the same applied to the other 3 anchor drugs. So there was no real evidence of excess weight gain among children receiving DTG and TAF. So what could we say in conclusion? In conclusion, what we can say from CHAPAS 4 is that children in this clinical trial did very well. And what we see is also that dolutegravir-based regimens were superior to standard of care second-line PI-based, and they also had a favorable safety profile. And this was particularly important in children who were previously exposed to NRTIs. And as you saw from the first slide, from the first few slides, the mean duration on first-line ART was 5.6 years. What we also saw was that boosted Darunavir-based regimens were as good as, and also showed a trend towards superiority to combined boosted atazanavir as well as boosted lopinavir regimens. We also showed that boosted atazanavir-ritonavir-based regimens were as good as or non-inferior to lopinavir-based regimen. Importantly for children, really, is that lopinavir-ritonavir had the poorest weight gain, and it had the least favorable lipid profile, which is particularly important in children. So these results from the CHAPAS 4 study reinforce the current line ART for DTG naive children, but it also gives us additional options for second line, such as boosted darunavir and also boosted atazanavir-ritonavir. So really a move towards producing child-friendly fixed dose combinations of FTC, TAF, plus DTG, or darunavir-ritonavir, or boosted atazanavir would increase access to safe and effective second-line ART options for children. I would like Victor did, to acknowledge and thank all the study participants, their families, also appreciate the funders of the study, and as well as site staff for seeing this trial through one of the worst pandemics in recent times.
My question to both of you, in your respected countries, how do you see CHAPAS 4 going to change guidelines, and do you see any issues with implementation at the current time, when most of children are already on dolutegravir first line? I don't know, Victor, Mutsa, who wants to go first?
Let's give Victor the chance first, because he presented first. Some very interesting and challenging, thought-provoking questions that we've all been scratching our heads about. So Victor, over to you first. I think there's 2 sections to the questions now. There's one is what's the implication of these results in the light of most children now failing on dolutegravir if they're failing first line, and how do you think this should affect guidelines in your region?
For the guidelines, we think these CHAPAS 4 results are actually going to, first of all, reaffirm what had been observed, especially related to dolutegravir, what had been observed in Odyssey, that these dolutegravir-based regimens provide superior suppression and also quite safe. But also the dimension they add is to the NRTI backbone, which is the TAF FTC. Previously, what we had was TDF, which could not be used in children below 30 kilograms. But now we have an option to use TAF FTC from children as young as 3 years, and with a weight as low as 14 kilograms, even much lower than that. So this means that we can have probably regimen that is similar to what people have in adults, tenofovir-based regimens, but with a safe option that can be used. So that makes procurement easier and other things and planning. So yes, there will be a change. And I think the biggest change, or the first one that I will see, is probably inclusion of tough FTC within the guidelines, which currently is not there as an option.
Thanks, Victor. And before we hear any comments from Anna to your responses, then should we go to Mutsa to hear her thoughts?
Yeah, thank you very much. It's indeed a thought-provoking question. And I think, like Victor said, tough FTC has not been on the horizon. So definitely CHAPAS 4 results is going to push countries to make sure that we include tough FTC, particularly because of those definite advantages that we are seeing in growth. But also to just say, not enough children in our part of the world in low resource settings where there is the highest burden, they've actually switched to second line art. And that's even while they are failing, you still find that particularly in more remote areas, they continue to be on a failing regimen. And most of the times it's really because there's hesitancy in putting children on something which is not an FDC. So my thinking is that as we have produced these results, we will now, it now really encourages the pharma community to make FDCs, which will make it easier for dosing so that many more children who are failing first line ART will not be limited in terms of moving to second line ART because of the drug formulation. And I think the findings that lopinavir, ritonavir really is not that best drug. I know it was shown in P1060 to be superior to NRTIs, but I think we have definitely shown that in children and also adolescents, it's not doing much in terms of their growth, and it's actually doing quite badly in terms of our lipids. So I think we will be able to, this evidence will also push countries to start thinking twice about maintaining lopinavir, ritonavir as a second line option for children. Thank you.
Thanks, Anna. Thanks, Mutsa. Anna, any final quick comment in relation to those responses, and then we've got some other questions we can ask as well from the chat.
Yeah, a very quick comment. Thanks, Mutsa and Victor. I think it's definitely going to push the development of a co-formulated Darunavir and ritonavir pediatric formulation, as well as tough FTC combined with dolutegravir, which you know, we as a pediatric community and researchers work very hard. And hopefully that also will push the question whether tough FTC as a separate NRTI backbone co-formulated should be also available if you want to combine it with PIs. So this is all questions kind of going through my head now. But anyway, lots of questions, and I will probably come back and ask some of them if we have time. But thanks.
Thank you very much, Anna. We have time for a couple more questions. I'll do one from the chat, and then Hermione has raised her hand as well. So from James Nuttall, fantastic study and exciting results. Is there any reason to believe that tenofovir, FTC, dolutegravir would be similarly effective after failing first-line lopinavir? That's the first question. And the second question is, was AZT3TC worse than abacavir 3TC in second line dolutegravir based regimens, as it was seen in Nadia? Victor, would you like to take the first question?
Yeah, thank you. So the one, is there any reason to believe that tough FTC-DTG would be similar after failing first line lopinavir? I think there would certainly there would be similar. I would believe there would be a similar kind of observation in my view, because what we saw when we compared the DTG-based regimens with the other regimens, the anchor drugs, there was still poorer response to the lopinavir investment. So it may not be as marked, but probably there will be some improvement with that. The second part was that is it worse than abacavir TC? No, it wasn't. There was no difference between AZD3TC and abacavir 3TC. So that difference was not driven by either. So those two are similar.
Thank you very much, Victor. Hermione, you've got your hand raised.
Thank you, and it's wonderful to see the results of this beautiful study. What it raises for me, I guess, is the following on from what Anna was saying, is that actually if TAF is superior to abacavir or Zidovidine, will people start using that as first line with dolutegravir? And does that, you know, then what is the follow-on going to be after that? I'm just wondering what your thoughts are about how it will be placed in first line as opposed to second line.
Thanks, Hermione. Mutsa, would you be happy to answer that question, or if not, then Victor?
Yeah, sure. So I think one of the things that we know for sure in this part of the world is that the way from first line to second line, or even when we initiate we don't have any baseline resistance testing. And when we move to second line, we also don't have any baseline resistance testing. But because we collected baseline samples and samples in CHAPAS 4, we're hoping that as we conduct retrospective resistance testing on those stored samples, we will be able to really have a better handle of what was the resistance pattern given the regimens that the children had been exposed to, because I think we will really need that evidence in terms of moving forward and actually proposing, you know, second line regimens and so on. I mean, the one thing about children is, particularly in our part of the world, is because of the change in guidelines, and also coupled with sometimes stock out of drugs and so on, you find that children change regimens because of stockouts, children change regimens because of sometimes failure, and they tend to have been exposed to quite a number of drugs before they even formally fail, as it were. So I really think that the resistance data will be able to inform this process.
I think my presentation very logically follows presentation by a fantastic team of investigators of CHAPAS 4. I'm presenting on behalf of multinational team of investigators. This is unpublished data, so please do not disseminate slides. We have a paper that's been submitted as we speak. And I'm very happy to share with you results of a totally different angle, looking not through the clinical trial of the drugs, but through the standard of care clinical practice across multiple countries. So to start with, I'd like to explain why focus on Darunavir. I'm working as a senior technical advisor with Elizabeth Glazier Pediatric AIDS Foundation. I've been leading this project since 2014. And here I can say that we started working with a partnership with Johnson & Johnson in an amazing donation program where recognizing, mentioned by Dr. Mutsa, the high cost of Darunavir, they started donating the drug since 2014 to eligible countries. Countries needed to apply. And also the Etravirine. We know Etravirine has fallen out of favor on the global guidelines and the majority of national guidelines, but at the time, it was still a tangible drug as well. And it was also part of the donation that focused on primarily supporting advanced treatment options, children who have failed first, second line, going to third line treatment, and obviously need to comprise a strong backbone. So despite the fact and recognizing, you will see in the data the minimal use of Etravirine, since company was making it both pediatric formulations and the adult formulations as well, are donated through this program for now 9 years. Next year, we plan to celebrate 10 years anniversary of the collaborative. And the collaborative exists in multiple African countries. Here you see the list of the countries, and in all these countries, we do a lot of work beyond just drug donation. Drug donation program is handled by the company itself. It's except the South Africa. I'd like to point out South Africa does not receive donated product, but we do recognize that identifying treatment failure, treating treatment failure, working on it requires a certain level of expertise. And we do recognize that this expertise has been suboptimal in many settings. It requires a lot of knowledge to deal with issues like resistance, to deal with issues like interpreting resistance results, looking at sequencing of ART. So we've been doing, and you see here listed, a lot of other things to advance the knowledge and capacity of ART, and not focusing specifically on the product, but rather trying to straighten the whole cascade of ART care in pediatrics, including training workshop, technical workshop. The last workshop we just had was held end of August in Lusaka with country participants. And in this particular study, not all the New Horizons countries went in, so you see the slightly smaller number of countries, but nevertheless a very significant representation of sub-Saharan Africa. What we decided to do early on in a collaborative, when we started the numbers of children and adolescents and young adults, and by the way, I didn't mention that the collaborative donates the drugs anywhere from 0 through 24 years of age, and then the patients are expected to transition to national supplies through national adult recommended regimens. We started asking ourselves questions. Let's look at these children. Let's see what the outcomes will be. How are they going to do? From what regimens are they coming? And at that point, the concept of the study was born. So the study was funded equally by Johnson & Johnson, and it is run as a separate study, but it complements New Horizons Collaborative. I do want to be clear that in the study, when we go to the facilities, and majority of them are centers of excellence, that's where the third line in a majority of the countries is considered, we do not differentiate whether children received and adolescents and adults received Darunavir or Etravirine through the collaborative or not. It's basically all the patients at those facilities who are prescribed Darunavir or Etravirine-based regimens we collect the data on. And again, the aim is to understand the demographics, clinical laboratory characteristics, describe the profiles, and we come back to all these facilities every 6 months. The project started in January 2019, runs through December 2022. We still have some data analysis ongoing. I'm not going to present you the whole wealth of the data. Again, it's going to be in the manuscript, actually a couple. And then we wanted to also look at the resistance data along with some anthropometric data, whether the dosing corresponds to the actual weight and recommended doses, and then following the patients after we transition of the program at the age of 24 up to 12 months after they transition. This is a journal study design, high level, I think I already covered some of it. And what I want to differentiate, we started by looking just third line, and then we said, okay, if Darunavir Etravirine are prescribed as a second line, and that's very relevant to ongoing discussion, what are we going to do with a true confirmed DTG failure? We also included them. So while we designed the studies focusing on the third line, we did not discriminate when collecting the data where it was a third line or second line potentially. And I want to recognize right away, not only the investigators, and pay big tribute to patients and the families whose data we are collecting, but really express a big gratitude to Ministries of Health, because all the facilities, IRB approvals, many countries, leadership in the pediatric ART, like in Uganda, many of you know Dr. Eleanor as a PI in her country. In each country, we have a relevant PI. They have been extremely helpful in conducting the study and very enthusiastic in getting this data move forward. This is a high-level overview. Again, I'm not presenting in detail data, and given the time constraints we have, I'm happy to answer any details in summary. You see here the country distributions. The largest by far contributor to the study is Uganda, which has the most decentralized model at the national level of managing treatment failure in pediatric populations, including pharmaceutical decentralization, provider decentralization, prescriber, etc. And the second largest cohort came from Zimbabwe, followed by Eswatini, but you can see each country contributed, even smallest number from Rwanda, but we had data collected in every country. The median age, not surprisingly, of those looking at the third sequencing, because the Darunavir national guidelines of the majority of the countries following WHO guidelines is only currently listed in the third line, is a fairly adolescent, though we had as young as you can see here as 0.2 years of age. Where young cohort was quite modest in the study overall, but we had few kids who were extremely young and had already required this transitional consideration. I want to remind everyone that the Darunavir is not approved under the age of 3, and this was youngest age cohort. Definitely is we're looking at Etravirine considerations, or at least considerations for any of this regimen, but just for the full disclosure, these are single digits patients with very complex history. Male, female patients, and then you can see here referral facilities. And some of this data, we had limited data in the medical chart, and I want to recognize it as I go forward. As many of you know, the programmatic data has gaps, and you will be seeing these gaps, and you will see the numbers of the patients change depending on what we were able to recover from medical charts, because all we worked is were medical charts. So you can see here a total patients that we collected the data on 871. We looked at the patients from which regimens where they transitioned to the Darunavir-Etravirine-based regimen, and these were primarily boosted protease inhibitor-based regimens, lopinavir and atazanavir-ritonavir. So that's not surprising, I think, to anyone, because of the national guidelines and sequencing of ART. We are using very small proportion transition from NRTI, but there were a very small proportion, nevertheless, transitioning from DTG-based ART, going to the discussion that was raised before. If you look at the regimens we highlighted in the red box, you can hear that the majority switched to DRV. The use of Etravirine was very small. And what I want to point out, the DRV, the Darunavir, was used largely in combination with integrase inhibitors. It's either dolutegravir or altegravir, adding Etravirine or altegravir, but you can see that combination is very common. And we have a sub-analysis. I'm not presenting it today to see in which proportion people actually considered or dropped NRTIs and just left this dual combination of INSTI with boosted PI. So this analysis is ongoing. I don't have these numbers. We looked what was documented in the chart as a reason for the switch. The reason for the switch was resistance, and in a large proportion of cases. It didn't mean that we were able always to recover the actual sequencing of the resistances. I will show you data. The numbers there are a bit more modest, but we tried to do our best to recover a resistance, actual record of the resistance with mutation listings. We didn't succeed in all of the cases, but it looks like resistance was the main driver. Defined virological treatment failure, small proportion relatively, but still significant, was non-adherence. A very small proportion was related to toxicity or side effects. And then we looked also at the viral load 6 months, within 6 months prior to the switch, and it's listed here on the slide. When you look by the number of drug mutations, and these are the patients 386 where we did have actually sequencing information that we could extract from the charts, you can see that there were almost no patients who did not have any NRTI mutations, and NRTI and API, not surprisingly, were the best protected class of the drugs. And here are the mutations listed by across all the whole cohort. There was not much variability between the countries. Again, not showing this data right now. There were quite similar results. Not surprisingly, for NRTIs, you see a single leading mutation discriminatory listed M184V. You see very low number of K65 mutation, and you see a good range of the TAM mutations. When you look at NRTIs, again, unsurprising, leading mutation is Y181 and K101. And here are the mutations for the boosted protease inhibitors, also multi-class mutations, you can see leading as well. We listed this by the drug sensitivity. And again, going to the discussion and CHAPAS trial results, I want to reference here, you can see obviously FTC and 3TC having the highest rates of resistance, no wonder with the 184 leading mutations. And for the discussion between abacavir, AZT, and TDF, you can see that the best protected drug is TDF, and not surprisingly, for pediatric populations as well, but it goes along, I think, and complements nicely the also CHAPAS study from real world scenario that we have seen efficacy, such a great efficacy with tenofovir-based regimens. And I do want to comment here that in the resource-rich settings, I practice as a clinical provider in the United States. TAF now constitutes a first-line preferred regimen across the border, and it's been used in quite young children with a great success. So I think the questions that were raised by Hermione and Anna about sequencing, and to my knowledge, some national guidelines have defended and have TAF available formulations, at least for adults and adolescents. In Zambia and Lusaka, where we held a technical workshop, Ministry of Health has shared that TAF FTC combination is available, and also combination with DTG generic is available as well as a single tablet. Looking at NRTIs, again, not surprisingly, the biggest losses for nevirapine and efavirenz, and I think very much in line of what we have seen in some other studies. I think at pediatric workshop in Brisbane AIDS conference, we've seen some data on surveillance from Eswatini on resistance, where about 30% of patients has lost rilpivirine sensitivity, and our data kind of corresponds to the same, or I apologize, to the same, close to 30% there. And Darunavir second generation RTI, but really not used on the continent. Where I'd like to focus on what resonates the trend observed in CHAPAS trial is a best preserved boosted protease inhibitor is Darunavir. As you can see clearly in our cohort, when we looked at the resistance profile, Darunavir had the least resistances compared to atazanavir and compared to lopinavir, which were all pair in terms of resistance here. And when you look at the resistance data broken by ages, and the red bars are youngest, again, we had very small number of children there, 5 to 9 years of age, yellow bar, light blue bar, 10 to 19, and 20 to 24 years is a dark blue bar. Again, if you look at the percent of participants who are susceptible, above 50%, you can see here that Darunavir was a leading drug. Obviously, I do want to recognize throughout the whole presentation that you saw the majority of it was prescribed in combination with DTG in terms of viral efficacy in the study, but from the resistance profile, we haven't looked at insta resistances here. And in the same Eswatini surveillance study that I have cited that we have seen this summer, I think the DTG resistance was around 15% in the national surveillance pediatric data. Well, now looking at the viral suppression rates, here you can see it listed on the slide at 6 months after the start of primarily Darunavir-based regimens to the 12 months. And you can see here broken by ages without really much difference between different age cohorts. And overall, we saw the viral suppression below 1,000 copies in almost 80% at 6 months, and slightly lower, but not significantly going down at 12 months. And when you look at viral threshold below 50 copies, you can see here that the percentage were smaller at 6 months, and then but stayed very stable at 12 months. So we are seeing quite degree of low degree viremia. And again, going to the presentation at the pediatric workshop in Brisbane this summer, we saw fantastic work from Baylor, Tanzania, which has looked at the low degree viremia in pediatric and adolescent patients, and so a great predictive value of future therapeutic failure. So I think we are moving into the era of starting paying much closer attention to this low degree viremia. And then the study presented from, I believe it was Dr. Mackenzie who presented on behalf of Baylor Tanzania team. They highlighted that the high degree of viremia was the higher were the chances of predictive in terms of the future treatment failure. So I think for us, it's really important to recognize this below 1,000 copies that we used to accept on a journal level, but now start looking more closely at this gray zone. Here you can see the values very much echoing what I've been discussing. Here, a large proportion of a low degree viremia.
Natella, sorry to interrupt you. You have a few minutes left. Do you think you can manage?
I have 2 last slides.
Okay, thank you.
And here, the end of the study period, just to show you that despite the challenges and very highly treatment experienced cohort, we are having with you here a very good retention in the standard of care. This is non-clinical trial. So I really am pleased to see that alive and care was a very high proportion of patients. A small proportion of patients died, and you can see transferred and lost to follow-up. So in conclusion, in this observational standard of care cohort, we have seen recognizing that there was a combination very largely used of darunavir with DTG-based ART. We recognize that in the third line option, we were able to have a fairly high proportion of virological suppression. And we saw that among all boosted PI retained the highest baseline sensitivity prior to transition. And Dr. Mutsa raised the issue about the cost of darunavir in this collaborative, to which each country can apply. We donated darunavir for free. However, I do want to recognize there is already available and approved since 2021 generic formulation of darunavir ritonavir in one tablet for 150 milligram. And the annual cost for this regimen that is available equally for adolescents is only $210. So this is really, to me, a strong advocacy point for considering darunavir as a sequencing drug to DTG, proven DTG treatment failures. We discuss more. And just to finish up, currently CHAI is developing pediatric formulation or co-formulated product for darunavir and ritonavir as well. I will stop here.
So I see a question from Anna in the chat. She says, Natella, congratulations. The suppression rates seen in this study, are they comparable to the rates seen in adults?
Yes, Anna, thank you very much for asking. We did look at the, and I didn't show this data today, we separated within this cohort adults, 19, 20, and through 24. We saw that pediatric populations actually were faster to suppress. If you look at the speed of suppression, which I didn't show the data, majority of patients who got suppressed within the first 6 months. We saw that there was a relationship with being younger, being suppressed faster. But to my knowledge, in other observational data in adults, these are comparable rates.
Thank you.
And just making sure I don't miss any written questions.
Any other questions for Natella?
I can't raise my hand, but I'll butt in. Sorry, as my co-chair privileges. Thank you. That's really amazing data and lots of food for thought as well. I was just wondering, and I'm sorry if I missed it, what proportion were on BD Darunavir? We discuss a lot of cases moving to third line and debate about the pros and cons of switching to a high pill burden regimen. And so, yeah, what proportion were on BD Darunavir?
You mean BD twice daily?
Yes.
Right. So I don't have this data in front of me. Majority of the patients went twice daily because if you remember, Alasdair, the recommendation by WHO and treatment appendix was always twice daily. Only in 2019, around 2020, that we try to push, and there is now a footnote to the table that allows, and I want to thank Anna for being an advocate for it as well, that allows now once daily darunavir ritonavir use if you don't have mutations or if you don't have PI prior experiences. Because there were prior experiences of PIs here, majority of patients were placed on twice daily, though we've been through our technical and capacity building work, strongly advocating for the countries to learn what we do already for many years. If you don't have darunavir-associated mutations, and darunavir is quite well protected drug, as you saw, you can prescribe darunavir ritonavir once daily. So there was a small proportion that was prescribed once daily, but it's not significant. And I think there is still a very lingering effect of seeing darunavir ritonavir only as a BID option for a very long time. Equally, transition to generic, despite the approval since 2021, only started happening in one country right now, Zambia. And the other ministries of health are currently, I think, moving forward to requesting and having this formulation available, but we have not yet seen a strong uptake of this new generic formulation, which is allowing for once daily dosing. Thank you. Just to finish up on this discussion of the sequencing, darunavir generic, those of you who have not seen, there is a great CHAI tool on introducing new generic darunavir, and it does very well justify and shows, and I'm not going to take too much time with the data, that it's still possible to use the third line darunavir, even if you are going to face some treatment failure, by doubling the dose if you started with once daily and going on a higher dose. And I think what we have seen in collaborative over years, and I think Hermione raised this issue and Johanna as well before, is are we moving away from the philosophy, let's save the best for the last? Are we going to say we're going to have 2 strong drugs up front available? That's up to discussion. I know it's going to generate a lot more, but I think we have seen over years, in particular through that collaborative, that very strong mentality, which we ourselves instilled for years. Let's save the best for the last and not touch it until the last resort. I see Pablo. I don't know if I still have a minute to answer.
Hi, Natella. Very nice presentation. I was going to ask you about this very small population, but very important as well, that they are the ones that are heavily resistant to everything. And, you know, we share a trial with Fostemsavir. So we're thinking, are you seeing this population in your study in which they have no alternatives? We suppose
Yes.
you see, but can you comment on that?
Yes, the only caveat there, Pablo, that we are not able to test for DTG resistance, and the majority of the data, as you've seen, we didn't even show. The insti resistance testing just starts picking up. But a lot of these children who have major adherence issues generally have been exposed to raltegravir and have been exposed to raltegravir with a treatment failure. So my suspicion is, and I won't be able to say would they be, for example, candidates for Fostemsavir, but my suspicion is yes, except that we did not barely have records of the insti resistance only in a recent maybe year or so that we have seen in the practice people start looking. And at our workshop, Pablo, we always have cases. Each country comes in with 1 or 2 clinical cases, and they are bringing insti resistance cases, pan resistance to integrase inhibitor, which we start seeing on cases basis yet, maybe not in a huge numbers, but my estimate is from what I have seen between 15%, something similar to what I've seen in surveillance, that we start seeing this on the ground. And I think this is raising even more conversation about what our options will be, and will we be able to do Darunavir, Ritonavir, BID, and recognizing the pill burden. I think one of the biggest barriers to Darunavir was not just the cost, it's also, if you look at how you dose children, it's a large pill burden because Ritonavir is separate. There are multiple tablet formulation you need to combine. And I think with generic, even recognizing that we are going to still deal with issues, the issues might be simpler. And on the side of the guidelines, I do know Zambia, for example, now has added Darunavir in the preferred guidelines along with other boosted PIs. And that's a very important conversation to carry forward in light of therapeutic philosophy we instilled all these years.
So, okay, considering the time, we have one last question from Hermione, I think.
Thank you. I just want to, I agree with what you've said, Natella, that we are also beginning to see children who are failing on dolutegravir first line. And that is probably related to adherence and stockouts and all the issues that Mutsa mentioned. And I suppose my question, exactly as you said, is if you are using dolutegravir backed up with tenofovir TAF, is that going to be more protective than using dolutegravir backed up with abacavir or zidovudine? And I guess, you know, we don't know the answer to that, but our hunch might be that tenofovir would be a stronger combination. I don't know, Anna, what your thoughts are about that as well. And also just to say that in the UK, we're a bit behind the times, but we're shortly hoping to get access to Biktarvy for young children, which is obviously starting with an Insti and TAF. And, you know, is that going to be a more potent first line and more robust first line combination with less issues of resistance developing?